This explainer is based on autoimmune inner ear disease, AIED, a vestibular physician's deep review, published by Australian Dizziness Clinics, available at australiandizzinessclinics.com. Welcome back, everyone. Right, so for our clinical audience joining us today, we've actually made it to the sixth and final module of our deep dive into autoimmune inner ear disease. We've gone through the whole shebang, from pathophysiology right up to medical management. But today, we're shifting gears. We're transitioning from the immediate clinical realities of managing this beast straight into the long-term outlook, the nuances of specialized care, and honestly, the most exciting part, the truly emerging science of AIED. Let's dive in. Here's our roadmap for today: the bimodal prognosis, relapse and monitoring, managing special populations, cochlear implantation, future directions, and finally, our key takeaways. Section 1. The bimodal prognosis, the ultimate decider. So, we need to confront a pretty hard clinical reality about the long-term outlook here. When you're facing AIED in the clinic, the timing of your intervention quite literally dictates everything. The prognosis is strongly bimodal. And the really fascinating piece of data is that approximately 2/3, yes, 2 out of 3 of your patients actually improve or stabilize if they get initial, prompt, high-dose corticosteroid treatment. That's huge. Early on, there's a very real chance of recovery. But if the disease is delayed or if it becomes refractory, it almost certainly tends toward progressive, permanent loss. The size of that initial audiometric response, that remains your absolute best prognostic marker. When you track the natural history of AIED over a 10-year span, that bimodal reality becomes incredibly stark. For patients receiving early immunosuppression, meaning treated within weeks of onset, their hearing thresholds tend to stabilize over the long haul. But then contrast that with patients who have delayed or untreated disease. The divergence is, well, it's brutal. The delayed group faces a rapid plummet right toward profound, permanent deafness. It just proves that the therapeutic window is incredibly narrow, and irreversible hair cell and neuronal loss accrues so fast with delay. Section 2. Relapse and monitoring, the chronic grind. Now we pivot from that initial rush of treatment to the ongoing chronic grind of management. And I gotta warn you, this disease is almost never a one-and-done scenario. Even for that 2/3 who respond right out of the gate, the proportion of those patients maintaining that improvement falls off markedly over subsequent years. Think about the standard clinical trajectory. You do your active induction treatment for the first 2 to 4 weeks with high-dose steroids. Then, you assess that initial response. Next, you start the tapering phase. Now here is the kicker. Relapse upon steroid tapering is actually the rule. It's not the exception. A too rapid taper is the most common, avoidable cause of relapse, often precipitating an audiometric decline within just weeks. And because long-term high-dose steroids carry such heavy, well-known toxicities, your patients who relapse predictably during tapering are your absolute clearest candidates for the early introduction of steroid-sparing agents. Because of this constant, looming threat of relapse, relentless monitoring is your lifeline. Serial audiometry really is the clinician's monitoring backbone. You need frequent testing, every 2 to 4 weeks during active treatment. Once the patient stabilizes, sure, you can lengthen those intervals. But, and this is crucial, patients must be explicitly counseled to present promptly for retesting if they notice any subjective change. Any at all. Early retreatment of a relapse offers the absolute best chance to recover those lost thresholds. So the mantra to remember here is treat early, taper slowly, monitor closely. Section 3. Managing special populations. Nuanced care. We also need to carve out some time for the exceptions in our patient demographics. Generally, AIED targets adults between their 3rd and 6th decades, right? But certain specialized groups require highly nuanced, proactive management. Let's look at 2 in particular. First, pediatric AIED. It's rare, sure, but the presentation is often acute and bilateral. The vital takeaway here is that children actually have a remarkably high recovery potential, provided the disease is caught and treated early. Then, on the flip side, you have secondary AIED. This makes up about 15 to 30% of cases where the inner ear disease is just one symptom of a broader systemic autoimmune issue. For these folks, you aren't a lone wolf. This demands strict co-management with rheumatology, because controlling the underlying systemic disorder is absolutely integral to controlling the ear. Section 4. Cochlear implantation, the surgical safety net. Now, despite our absolute best medical efforts, a significant subset of our patients will progress to severe bilateral SNHL, that's sensorineural hearing loss, indicating severe damage to the inner ear or the nerve pathways. For these patients, we have to activate the surgical safety net.
Hearing rehabilitation should always run in parallel with disease-modifying treatment, never just as a last resort. But keep in mind, there is a rapidly closing window for cochlear implantation. Step 1, severe bilateral loss develops despite medical therapy. Step 2, you must use serial MRI monitoring to check for labyrinthian patency. Why? Well, that brings us to steps 3 and 4. Chronic inner ear inflammation can trigger labyrinthine fibrosis and new bone formation, essentially obliterating the scala tympani. If you sit on it and delay the surgical referral until every last decibel of hearing is gone, what would have been a straight cord implant candidate becomes a complete nightmare of a surgical case. Timely imaging and early referral are what protect your patient's future options.
Section 5. Future Directions, the Scientific Horizon. This is my favorite part. This is where we finally move past the limitations and the toxicities of our current broad immunosuppression and step into the real scientific optimism defining the future of neuroodology. The scientific horizon is all about biomarker-defined subgroups. The future is not treating AIED as a single monolithic disease. It's recognizing it as a final common pathway of immune injury. A major game-changer recently has been the identification of interleukin-1, or IL-1, a key inflammatory cytokine. Recent advances are showing us that targeting specific pathways, like using anakinra for IL-1 blockade and corticosteroid-resistant AIED, yields measurable, real-world audiometric improvement. While this shift toward biomarker-guided, cytokine-specific therapy is incredibly promising, I should note the field still has a critical unmet need for ratified diagnostic criteria and a standardized practice guideline. Section 6. Series Conclusion and Takeaways. Okay, it's time to wrap up this 6-part explainer series and really synthesize this complex clinical journey. To completely solidify your understanding of AIED management, here are the absolute core principles to take back to clinic. Number 1, the outlook is bimodal. Early, aggressive treatment can arrest or even reverse the disease, while delay almost guarantees permanent loss. Number 2, expect relapse on tapering. Your entire management strategy lives and dies by relentless monitoring via serial audiometry. And number 3, the future is incredibly bright. It lies in moving away from blanket immunosuppression and toward biomarker-defined subgroups and highly targeted cytokine-specific therapies. I want to leave you with a bit of a provocative thought as we close out today. We've relied on high-dose steroids, a real systemic shotgun approach, for decades, despite knowing their massive toxicities. But as we transition to targeted biologics and uncover specific immune markers like IL-1, will these broad corticosteroids soon become a complete relic of the past in vestibular medicine? It's a fascinating evolution to watch, and one that will ultimately save our patients' hearing with way less collateral damage. This concludes our 6-part series on autoimmune inner ear disease. Visit AustralianDizzinessClinics.com for the full review and companion materials.